Welcome to the monthly seminars at the Big Data Health Science Center at the University of South Carolina. Um, in this presentation, we would hear about using NLP or natural language processing and machine learning methods for analyzing substance use on social media. This seminar is hosted by Social Media Co. So um, I'm very happy that we host Dr. Abid Sarkar, that who is an assistant professor in the Department of Biomedical Informatics, School of Medicine at Emory University. He is also a program faculty in Department of Computer Science at Emory, and he's also, that in the Department of Biomedical Engineering at Emory. This is a joint program, a kind of joint program between Emory and Georgia Tech. His research interests are social media, NLP, and applied machine learning. He published several papers on using social media for health applications, and funded and received grants from NIH and CDC. Um, I'm so happy that that we have Abid here with a lot of experience on using social media for health application. If you have any question for this presentation, you can post your question on the chat box. Then we can ask this question from Dr. Starker at the end of this presentation. You are going to get a survey regarding this seminar, and we appreciate it if you fill this form at the end of this presentation. So again, I'm so excited to have Abid. So I'm reading his paper. I'm one of his fans actually. So Abid, the stage is yours, and we are ready for your great presentation.
Thank you, Amir. Thanks for the very kind introduction. I hope you can hear me well.
Yes.
Let me share my slide.
Awesome. I'm going to turn off my video to increase to avoid any interruption or
Perfect. All right. So thank you everyone for attending. As Amir mentioned, my research area now is involved a lot with social media. My background is computer science, specifically computational linguistics, and since my PhD, I've been working on medical text. Initially, I was working mostly with medical literature. I still do. I also work with EHR text, and also, but as I said, most of the work is on social media data. So, broadly speaking, my research lies at the intersection of NLP, machine learning in an applied sense, and natural, just free text data from the health domain. Over the last 5 years or so, we have been working on substance use and substance use disorder and studying that from social media. And the work is funded mostly by the National Institute on Drug Abuse of the National Institute of Health. Since I'm over at Emory, some of you may know that the CDC is pretty much on campus at Emory, so we also work a lot with the CDC. And of course, the disclosure is that the content is solely the author's responsibilities and not the CDC's or the NIH's. So let me start by providing a quick sort of overview of why we want to study substance use and overdose. So substance overdose related deaths and the epidemic of substance use related deaths has been going on for decades in the US now. There are papers that have studied it from as early as 1979 or something, and then it showed how substance use has increased, or deaths due to substance use has increased over time. Specifically, in the last couple of years, there has been a very sharp rise, primarily due to the distribution, the widespread distribution of fentanyl, and specifically the contamination of the opioid supply with fentanyl. And although the trend has been very similar over decades, as in increasing. The primary contributors to death have been changing. So way early in the 90s, it was cocaine, crack cocaine. Then there was a period of prescription drugs. Then there was a period of heroin, and now we're going through another wave, which is fentanyl. We are also seeing rise in benzodiazepine related deaths, and also stimulants like cocaine. One important thing to observe here, other than in addition to the growing number of deaths, is the x-axis here. So we are in March 2022 now, and we only have, the last time I checked, which was last week, we only have provisional estimates of overdose deaths until September 2021. So there is at least a 6-month lag involved in the surveillance. In fact, by the time we get final results, it's over a year. So that shows that there is a big problem in surveillance. By the time we get to know what is happening with the overdose crisis or substance use crisis, it's already typically too late, and the trends have sometimes already shifted. So what is needed is a more real-time source of surveillance to address the lags or associated with traditional surveillance methods. So one of the sources of new, like, novel surveillance that have been pointed out recently is social media. And the reason we want to use social media is because social media has excellent reach. We know that social media adoption has been growing. It was primarily popular among younger people for a long time, and now as time is progressing and the demographics are shifting, we're seeing more and more older people on social media. I think over 70% of Americans now use some form of social media, and as a result, social media as a whole allows us to reach people that we could not reach in any other way. For example, substance use cohorts are very hard to follow. They would go to one emergency department at one time and somewhere else another time, depending on if they're having an overdose or not. There are also other communities like people who are uninsured and so on, but they're all on social media mostly, and we can study them using it, possibly at close to real time. So when I mention this and tell people that I study substance use over social media, the first question I get is, do people talk about these things on social media? And the answer is yes. Any topic that you can think of, it will have some information or discussions on social media, absolutely every single topic. Substance use related chatter is actually fairly common in social media. People very commonly share experiences and self-management strategies, often anonymously. So you have to understand, if there are 100,000 people dying in a 12-month period from substance overdoses, then the number of people using substances is way higher than what we probably know about. And a lot of those people need information or are struggling with to maintain their lives while also trying to get over the substance use disorders. And so social media is a great source for them to go to obtain information and find support. And there is, like, now a realization that social media is so important, and as a result, there is a growing interest and amount of research on substance use using social media. However, research is still very much in its infancy for this topic. So let me quickly give you an outline of the things I will sort of talk about. I will very briefly introduce the distinct social networks that we use and the challenges associated with it, or the characteristics of each. Some of the technological advances and innovations, although I will focus more on the applications and the findings that are sort of more generally relevant. And I will also try to talk a little bit at the end about unexplored opportunities. So the question is, how can we utilize social media for substance use research? Just because people are talking about it on social media does not mean that it's an easy resource to mine data from. And in fact, that is one of the reasons why we are lagging so behind in terms of social media mining. Social media data presents a lot of challenges. It's big data. The data is being constantly generated, and as a result, there's a lot of overload of information. Data is also very noisy, meaning that most of the substance related chatter we get from social media are not actually about personal use, but they're about other things. They can also be on unrelated topics, like they can be song lyrics and stuff, which we have found to be the case often. And that makes it more difficult to ascertain if a data obtained from social media is reliable or not, or how reliable it is. So to effectively use social media, which we have been trying for a while, and to convert social media data into valuable and actionable knowledge that can be used by domain experts, what we need is to develop advanced artificial intelligence systems, specifically natural language processing and machine learning models that can filter and characterize data and present it in a way that is useful for the domain experts. Um, so our work over the last few years has involved an epi component. So the epi component is more about surveillance and understanding how substances is being used, what substances are increasing in trend, how they're location-wise distributed, and so on. And there's also a clinical component, which is where we have our collaborators in emergency medicine mostly, and they come up with questions, ask us those questions, and we try to go to and mine social media data to identify those answers. Now, social media data, like a lot of people who have not worked with social media think that like all social media data is the same. It is not. The type of content and the language patterns, etc., they vary significantly from one social network to another. And as a result, the type of content we find is also significantly different. So two social networks that we use pretty frequently these days are Reddit and Twitter. Twitter has been around for a long time in research. It provides the public streaming API, which we can sort of use to collect data about specific substances. Twitter also provides geolocation information often, subscriber level information, and some other peripheral information that can be important, like age, gender, and so on. Problem with Twitter is that the posts are very short, lack context, and often the information provided is incomplete. Reddit somewhat takes care of that. Reddit now has a user base of that's bigger than Twitter, and it does not have length restrictions. As a result, it has very detailed posts about how people are using substances and what their concerns or thoughts are. So for example, we see here that someone is talking about PWDs, which is precipitated withdrawal, which I will get back to later on. So Reddit gives us more information about the clinical content, things like self-management strategies or what people are experiencing, which can sort of provide knowledge to our domain experts. So to convert social media data into valuable and actionable knowledge requires several layers of processing. So we almost invariably have a pipeline of machine learning methods which directly, which are end-to-end, which start from collecting social media data or strategizing on how to collect social media data, goes all the way to generating specific trends or patterns that can be manually studied. Now, an example of the data collection strategy from Twitter is that Twitter has, as I said, it has the public streaming API, so we can collect data using keywords. But a problem we faced early on was when we realized that even medication names are misspelled on Twitter. And that's a very common thing because no one knows how to spell Seroquel, for example. And so what we had to do was figure out mechanisms to automatically generate misspellings that are commonly used for different medications, and then use those misspellings along with the real spellings for collecting data from Twitter. And then some of the other layers involve classification into non-medical use versus medical use. So there is also a subtle difference here between prescription medication use, which is what we study a lot, and illicit substance use. So if someone says, I took a pill of OxyContin or Adderall or something, that does not mean that that person is non-medically using it. That may mean that the person is prescribed. However, if someone says, I took a bit of heroin, that is illicit use right away, because you cannot, like, it's not legal. So that's an illegal consumption or substance use. So now let me now take you step by step through some of the studies. There have been too many studies that we have done in this space, so I cannot go into detail with all of them, but what I want to do is give you an outline. So one of our first studies involved preparing data for supervised machine learning, because less than 10%, we found that less than 10% of the data or posts from Twitter that mention abuse or misuse prone medications, only about less than 10% of them are actually talking about personal non-medical use. So we first annotated a large data set, which is publicly available for anyone. I mean, there are some security protocols that we have to follow because of NIDA's rules, but then if you send us an email, we will share the entire data set with you. And we basically experimented with many different classifiers. The entire data set is double annotated at least. In many cases, they're triple annotated with an agreement of 0.86. So once we had prepared the data set, we applied many different machine learning algorithms. We discovered the best ones, which was not very surprising. It's one of the BERT-based basic models, which ends up giving us the best accuracy. And then we plugged this machine learning classifier into our Twitter pipeline. So all the chatter flowing in, coming out of Twitter is classified in real time. And then those that are classified to be non-medical use, they are stored. And then those social media subscribers or users are sort of added to our cohort. Now, one thing we can do with Twitter and also with Reddit is once we detect a post that indicates non-medical substance use. So here, for example, we're using the white circles to represent that. Once we have that, we can actually go back and collect past available data from that same user, and we can keep collecting it over time, so that over the years we end up having thousands and thousands of posts from every single user. And based on this classifier, we currently have a Twitter cohort of over 500,000 users who have at some point or the other expressed non-medical use of prescription drugs. And then we have years of data for them, accounting for over, at the moment it's over 3.5 billion tweets, and it's increasing really fast. So within our EPI component, one of the first studies we did was to identify or determine if we can do geolocation specific surveillance. So back when we started this study, I was in Philadelphia. So we obviously chose the state of Pennsylvania. And what we wanted to do was use our classifiers to classify Twitter chatter from the past and see if the population adjusted rates of tweets were correlated or were indicative of how much substance use was going on in specific regions. So what we found was a lot of similarities. For tweets, unsurprisingly, we found that many disproportionately high number of tweets are generated from big cities. So in Pennsylvania, the two big cities are Philadelphia and Pittsburgh. So most of the tweets were coming from there. We found significant moderate correlation between overdose-related deaths and the tweet rates of counties. Importantly, we found like much better correlation when we only included counties with slightly higher populations compared to the others. We also compared our social media derived estimates from with the NASDA surveys, and we found in this case strong correlation between the social media tweet rates and several metrics within the NASDA surveys. However, in this case, we could not determine statistical significance because, as you can see, like NASDA, in at least in the case of Pennsylvania, divided up the map into substates, not counties. And so the number of data points we got were relatively low. But it was very encouraging. And later on, we ran it on other states, which is not published, and we found similar results. So one of the disadvantages of social media, or one of the areas where social media was lacking, was getting very structured or accurate fine-grained demographic information. So NASDA surveys, for example, breaks down the surveys in terms of gender, or biological sex. So currently, last time I checked, they had two like gender in a binary format. Then there are also other aspects like age group, race, which are all very important, interesting things to study. So after we had our classifier and our cohort in place, we started looking at, can we identify or characterize the gender distribution, the age distribution, and the race distribution in our cohort. So we started doing that. For gender, we looked at we modeled it in a binary classification problem because again, we don't have enough data to effectively determine non-binary cohorts or populations. Interestingly, for stimulants like Adderall, Ritalin, and tranquilizers like alprazolam, which is Xanax, clonazepam, and all that, we found the Twitter estimates to very closely resemble the NASDA estimates, and they were always within the confidence intervals. Interestingly, for pain relievers, which is what the primary cause of overdose-related deaths, which involves OxyContin and similar types of opioid pain relievers, we found that the NASDA estimates were off. And we found that the NASDA estimates were not only off from our social media-based estimates, but also from other types of sources of data. For example, overdose-related deaths are very skewed towards males. Emergency department visits are very skewed towards males, but then the NASDA surveys did not really reflect that. So we went and compared it with other sources, and we found that the social media based estimates, again, you can see the green and the blue bars here, they're very close in terms of very close to the emergency department visits due to opioids. So following that, we started working on age group and gender, age group and race estimation from the cohort. I must point out at this point that we do not, our goal is not to identify the age group or race of an individual, and there is also no guarantee that we can accurately identify the age group or race or gender of a specific person because our machine learning models are not 100% accurate. In this case, for race and age group, we're using a high precision method rather than a high F1 score method. And so, yeah, so we cannot tell if it is correct at the individual level, but when we have hundreds of thousands of users and we can run our system on that, we know that at least at 85 to 90% of the time our system is accurate. In fact, it's higher. And so what we lose in accuracy, we make up by volume of data. So similarly, we are finding very good correlations between race and the Twitter estimates and the NASDA estimates. For age group, it's slightly different. You can see that Twitter tends to underestimate age groups like older age groups, while overestimate for the 21 to 25 age group. So we're just writing up this paper now, but the broader thing, point that this shows is that we can basically not only collect streaming data from social media, characterize it in terms of non-medical use or medical use, but we can go way beyond that. We can look at geolocation-based estimates. We can do um, estimates based on demographic characteristics like race, age, and gender. And that is very important because for a long time, especially in substance use research, everyone other than white males were pretty much sort of not ignored. I mean, pretty much were ignored for a long time. Women were ignored for a long time. There's a lack of research in non-white population as well. So a lot of that can be sort of complemented. The incomplete information that we have from traditional sources can be complemented by data from social media. So using, so the studies I mentioned all this while are all from Twitter. We have also looked at Reddit for looking at trends. And again, interestingly, it'll take me a long time to go through all of these, but then let me go through the second one here. So interestingly, as you can see, heroin has been the highest contributor to deaths in recent years. But we know from our CDC colleagues that there has been a supply shortage of heroin and there has been contamination of fentanyl over the last couple of years. And that is reflected very nicely here. So you can see the proportion of heroin mentions goes slightly down over time, while the proportion of fentanyl in opioid-related chatter has almost doubled. Very similar to how overdose death rates have evolved over time. And so this shows us that we can also, before the official data or numbers are released, we can basically get early estimates about where the substance use epidemic is heading. That was important to us during COVID, because when COVID started, we did not know how it would be, how it would affect overdose related deaths. And of course, we could estimate from Twitter, from Reddit, which we will show a little late. I'll present a slide a little later. We did estimate that there's going to be a large increase in overdose related deaths, and that is exactly what happened. So this is sort of the epi or surveillance component. And then, as I mentioned, there is the other component that is more focused on informing our clinical collaborators. So some of our early studies focused on comparing substances or medications for opioid use disorder. So there are two evidence-based, the two most common evidence-based medications for opioid use disorder are buprenorphine, or the brand name is called Suboxone, which is buprenorphine naloxone combination. And the other one is methadone. So we did a study to compare how people perceived methadone and buprenorphine. And some of the themes or patterns of conversation we found were there was a lot of chatter related to access, especially with methadone, because people are required to go to methadone clinics, and for buprenorphine, they're only given limited supply. So access is a common discussion point. Other important discussion chatter that we saw is stigma. There is a lot of stigma floating around on social media associated with substance use, a lot of stigmatizing language. And we found that a lot of users tend to or express that they are avoiding treatment or avoiding services or support systems primarily because of stigma. And there are also discussions about stigma that are coming from medical experts or people who are actually helping them manage their substance use disorder. Some of our Reddit studies actually reveal some of the most interesting outputs. So to provide a bit of background, when people are started on buprenorphine or naloxone or this brand name Suboxone, the treatment is supposed to be like a chronic disease treatment, like diabetes. They're supposed to continue to take the medication over time to get back to remain in normal life. But that is not what happens in reality. In reality, when we explored Reddit, we found that uh, successfully overcoming substance use disorder for subscribers on Reddit, at least, or social media, means something completely different compared to what medical practitioners think. So for many people, successfully overcoming their opioid use disorder means stopping taking the medications for them. And as a result, there is a lot of chatter associated with how people can start on these substances or medications and how people can eventually stop. And what we found was that tapering was a very common discussion topic. So people provide suggestions or describe how they self-managed their treatment, how they tapered over time, and then what strategy works. So Suboxone, for example, comes in paper strips. And what people do is they basically cut the paper strips into 16 or 32 smaller pieces. And then over time, they slowly decrease their buprenorphine intake. We found that people try to jump off, as they call it, from these anywhere between 2 milligrams to 0.0625 milligrams or 0.063. And then we basically used NLP to identify what doses were they expressing success. So those who according to their own definitions, successfully recovered from their opioid use disorder by tapering off eventually, jumped off at 0.63 or 0.125 milligrams. There were very low success rate. Like a lot of people reported to trying to jump off at 2 milligrams or 1 milligrams, but then most of them also ended up discussing how they relapsed because of withdrawal and similar things. So this was the kind of study that we sort of helped our physician experts understand how people perceive substance use disorder or treatment to substance use disorder. We also, from those same discussions, tried to extract out how people or what other substances people use or methods people use to get over their substance use disorder and what they use to deal with withdrawal symptoms. So for example, in terms of adjunctive substances, we found Imodium to be very common, clonidine very common. People also reported exercise to be useful to deal with it. Marijuana, different types of benzodiazepines like clonazepam, Zolam, or Xanax, they're all common substances that people use. In terms of withdrawal symptoms, restless legs, diarrhea, fatigue, these are the most common when people sort of stop or try to decrease their buprenorphine or Suboxone intake or taper off. So this brings me to our latest study, which is probably the most interesting and also very fulfilling. So last year sometime when we were having one of our group meetings, our physician experts from Philly, actually, they were telling us how they are seeing, because they initiate buprenorphine at the emergency department, and they were seeing some people have this thing called precipitated withdrawal when they take buprenorphine. So what happens is, the rule is that you have to stay in abstinence for a certain amount of time before you initiate buprenorphine, because otherwise it gets you into precipitated withdrawal. But people were starting to have these precipitated withdrawals even after they've waited a long time. So our collaborators asked us to see if people on Reddit were talking about buprenorphine, precipitated withdrawal buprenorphine, and how they were dealing with it. So we went and looked on Reddit, and of course, yes, people were talking about it for years now. People have been talking about it. I think the earliest we found was 2018 or 17 or something. And then people were, subscribers on Reddit were discussing how doctors do not know or understand precipitated withdrawal and how they try to initiate them on large doses of buprenorphine, which ends up giving them those precipitated withdrawals. As a community, they had also figured out what was causing it. So precipitated withdrawal was primarily being seen in chronic fentanyl users. So apparently, as they figured out, fentanyl is absorbed by body fat, and as a result, they remain in the system for a long time, especially for chronic users. And as a result, even if you go through the period of abstinence that is required before you take buprenorphine, you get precipitated withdrawal. And we showed this to our medical experts, and then we ended up finding more. So since people are having these precipitated withdrawals, as people do on Reddit, they started developing their own self-management strategies. So some of the self-management strategy, the most common is microdosing. So what they do is they start with buprenorphine at a small dose while continuing their standard opioid use, which can be heroin or fentanyl. And they increase the buprenorphine dosage slowly over time, let's say a week or so, while slowly decreasing their standard opioid use. When we found this information there, we could not find, there are no clinical trials yet with this. There are some case reports that mostly were published last year and this year while we were finding these things. And one method that has become very popular and that is very commonly recommended by people is the Bernie's method, which is a specific regimen for coming up with or avoiding precipitated withdrawal when initiating buprenorphine. So you can see here that for fentanyl and analogs, we found the time to buprenorphine initiation and precipitated withdrawal like to vary wildly. In fact, one person reported having precipitated withdrawal even after like over 160 hours of waiting. For heroin, we don't see much discussion about precipitated withdrawal because people who are taking pure heroin do not seem to get them unless they've waited a very short period of time. So this is an example of how the knowledge we're discovering on social media are informing our physicians, because now our physician colleagues at different places are trying out these microdosing initiation strategies to get people start their treatment on buprenorphine and address this problem with precipitated withdrawal, which is still keeping a lot of people out of treatment, because once they experience it, they never want to go back. So as I mentioned, we started looking at, this is in collaboration with the CDC. So once COVID started, the CDC or collaboration from the CDC approached us, and we discussed how we can identify what types of conversations were common while once COVID started, or what were we supposed to expect. So what we did was we did a very basic analysis of chatter over time. We looked at periods, a pre-COVID period and a post-COVID period. And as you would expect, like we looked at the word COVID as well. It barely appeared before February 2020. And then as soon as February hit, it jumped, peaking around March. We characterized other lexical components such as phrases into topics like drug use, treatment, and access and withdrawal. And we tried to see which type of chatter sort of increased. And we can see that treatment and access also jumped right along with COVID once COVID started. And when we explored this, we found that it was because a lot of people were, most of the chatter was about methadone. Because you have to go to a clinic to have access to methadone, and a lot of people lost access to methadone because the clinics were closed. Some were even worried about going to the clinics and getting COVID, while people from some states reported how they were getting larger prescriptions of buprenorphine, which they really appreciated and which was helping them. So they were expressing positive sentiments about the modified prescription policies. So that sort of brings me to the end or near the end of my talk. So we have a lot of ongoing work. It's an ongoing project still. So we are now looking at, because we have such a huge cohort now, I mean, it's probably the biggest cohort of substance use, biggest substance use cohort ever. We have a few years of data posted by them. We can study in an aggregated fashion the clinical and social impacts of substance use at the cohort level, study the trajectories. We are also starting to look at, because we are seeing a rise in benzodiazepines. So 2 years from now, if you're still following the overdose related deaths, look up if the number of deaths caused by co-ingestion of benzodiazepines and opioids. And I'm certain you will see a big rise, because we're seeing a big increase in the conversation. Some of the things we have not looked at is intervention and support and outreach activities. So we don't currently have any social media based intervention. We currently don't have any social media based outreach, but those are definitely aspects we can study. So another ongoing work, because we want to, I mean, I'm leading an informatics project funded by the National Institute on Drug Abuse. So the objective is not to just build these tools, but to provide these tools to experts who can use them and hopefully reduce the number of overdose deaths. So we are also in the process of building a dashboard, which we plan to complete over the next year or so. So I've added a QR code for the dashboard here, and we're still figuring out, designing the dashboard to see what types of information we want to present on it. So any feedback on that would be great as well. So to summarize the things I discussed, I hope I'm on time. Yeah, I'm on time. So to summarize the discussion, developing the NLP and machine learning infrastructure for social media mining has a lot of opportunities for substance use and substance use disorder. It has big and many subscribers, and a lot of information is generated by this cohort that is hard to follow on social media. Surveillance can provide early insights and even very fine-grained early insights for targeted demographics. And it can also provide us some idea about emerging trends like the emergence of fentanyl. The bottom line is that there's plenty to do, and I mean, considering the number of deaths we are seeing every day, it's a very serious problem, a problem of high significance, and there's plenty that we can and probably should do. So that's the end of my talk. I would just like to acknowledge all my collaborators and the funders who have made our research possible. So I can take questions now.
Okay, thank you so much, Abid, for your great presentation. So I think that this is a time for the questions. Let me just arrange something here. Oh, okay, awesome. Okay, that was a great presentation, and that I learned a lot of new things. That from this presentation. So let's go with with the question. So the first question is from Hassan. That he asked the question that, is it possible to target a specific range of users in social media? How could access data for a specific group? I mean, does the privacy policies let that happen? I think you discuss about, for example, the age or the gender and something like this. But I think it's a good question. That it's good to be that you address it.
Yeah, so yeah, I can see the questions. So there are questions under Q&A and chat as well. So I'll go through the questions one by one. So we cannot target a specific, I mean, we can indirectly target specific demographics. What we can do is once we have the cohort, so we can run those estimates over the entire cohort. So again, I have to be careful to like make sure to sort of explain that this will not work at the individual level. There's no guarantee that anything, any of these are accurate at the individual level, but at the cohort level, they're fairly accurate. How did you do the estimation accuracy? So all the accuracy estimations are based on manual annotation. So yes, we basically over the years gathered a cohort, and when they specifically expressed their age or gender in the text, we annotated them. So there are many ways in which we can get people express their ages. A very common way is when they have their birthdays and then they post on Twitter saying, oh, today is my 18th birthday or 55th birthday or something. And right away, we know what the age of that person is. There are also things like people say, when I was 17 in 1935 or something, we can sort of deduce the age from there. So that's how we estimate cohort level. Again, then we aggregate the information, and then we sort of study them and do the statistical estimate. Which do you want me to just go through the questions one by one, or?
Sure.
Okay,
You
so
you made my life easy.
which API is used? Pushshift.io is used pretty often. We use the Pro API though, which is the Python wrapper for Reddit, Python Reddit API wrapper, something like that.
I mean, sorry, that I think the order of the question is if you go up, that if you address in that order, it would be great. So the second one is from Banky, great presentation, start with great presentation. Can you see that for the opioid treatment example?
Okay. How did you account for policies, the suspended, the need to go for clinical visit to get? I'm not sure I fully understand.
Okay, I can ask Banky that to add more details on the chat box. Let's go with the next one. What was the Twitter data? Yep.
Yeah, so there is no specific specification that says it's 1%, but Twitter has, we have changed our APIs from time to time. So we do have, most of the data is collected from the streaming API. Some of the data is collected by the search API from the user level. During COVID, Twitter also opened up a COVID-related stream, which we started using. And now we are using the academic Twitter API, which is the most recent one. Geolocation problem in Twitter. That is true. Again, at the individual level with geolocation, we do not know. There is, but once we aggregate it to thousands and thousands of people, we start getting signals from specific counties and cities. So we sort of base the estimates on those. Again, there is no guarantee that the user lives there. All we can do is take the Twitter estimates from past, map it to and compare it with some traditional data and see if there are strong correlations or not.
So that the next question is, that how did you deal with the fact that Twitter is used by a limited part of the population, considering the fact that you might be missing some important subgroups?
That is a great point. So the thing with substance use research is that no matter how you set up your experiment or your study, you will always invariably miss many different subgroups of important people. So yes, we are missing some people on social media. We have an underrepresentation of older people. We are also probably missing a lot from the academic community, because the academic community, I've not seen them talk about substance use or their own substance use that way. But yeah, so there is no data source that is perfect. Social media has its own challenges, its own exclusions. And I mean, social media will not really replace any of the traditional surveillance methods. It will just, the goal is just to complement them.
Mhm. Okay, awesome. The next question is that from Young Ren, and that the question is
Yeah.
that do you only collect the tweets with the geo information or use other methods to identify geo information in the text? And the second question is that for the age estimation, is there any way that you can justify the age group estimation accuracy?
Great question. So when the geolocation information is available, we use that. When it is not available, we use some off-the-shelf tool, like we used Carmen for a while to estimate geolocation. On Reddit, we cannot, but then there have been some studies recently where there were some estimates of where specific Reddit users lived based on their posts. So we try to gather them if they're available from Twitter. Otherwise, we try to estimate them. And as for the age estimation and any other race, age, we only rely on self-reports when the users report them, because we have over a 500,000 cohort. Even if a small percentage of them actually talk about their age or gender or whatever, even that ends up being a fairly large number for us. And which is sufficient at the moment. And the cohort is only going to grow. We are going to get more and more people in the cohort. So,
yeah, and I just wanted to follow up on this question a bit. That how did you handle, for example, spams, bots, and even misinformation, disinformation? Something like this.
that is a great question. So we have created a bot detection system while I was at Penn. So that is a very common problem, right? So we filter out a large number of bots. I am sure we still have some bots, but we're hoping that that because of the large volume of users, the whatever noise the bots are presenting are sort of wiped out. But we do have a bot detection system in place which uses a number of different features like text and text similarity and even post duration, post timing, and all that, because bots tend to post very differently compared to humans.
Yeah, that if you have a lot of data, it's going to reduce the impact of the bots in your result. You're totally right. That the next question is from Morteza, that he asked that, have you studied the sources of where these subscribers are acquiring this substance from, doctor prescribed or purchased from the drugstore?
Yeah, that is again a great question. We do see those information. Reddit now tends to remove sourcing information. So another thing, going back to the bot question, Reddit is actually very good for that, because all Reddit forums are heavily moderated. So the moderators will remove any bot type of posting, or the bots will be marked. And also, so to come back to this question, yes, we do see chatter about doctor prescriptions and where they obtain it, although sourcing is banned on Reddit, so they get kicked. People who try to source or sell, they get kicked out. We haven't executed a study on this, but we would be happy to if any domain expert is interested. We have the data, so.
Awesome. So, that I'm going to ask that there are multiple questions from the same user. So I'm going to try to provide at least one question from each of the, the user here and the participants. That this question is from George, that, that he actually asked that, I'm a health psychologist and now developing a social media intervention for non-medical use of prescription drugs in young adults. You mentioned that the number non-medical use notes on social media was relatively low. Would you mind talk a bit about more how you annotate non-medical use behaviors?
That is another great question. So this was so we have a big Twitter annotated data over, as I mentioned, like over 16,000 posts. And it was painful. We had to manually go through all of them. And as I said, they're double annotated and in some cases triple annotated. As the annotators went through them, we have our domain expert who sort of determined what would be considered as non-medical use and what would not be considered non-medical use. Then we prepared a massive guideline about it. So we have the entire annotation guideline and the annotations and the data publicly available. If you send me an email, I can point you to the data, or it should be on NIH Reporter or Google Scholar as well. So and as a supplementary material to the paper, the annotation guideline is available. So it presents all the different ways like co-ingestion, route of intake, taking more than prescribed, all those aspects. If there's any signal of that, we consider that to be non-medical use.
You know that I'm going to ask two more questions, and then you know that we are going to end this session. We get you know that a lot of questions, and I try to add you know that to get at least one question per each of the you know the users and participants. So you know that Denzi asked that would you please describe a bit more more on your dashboard system design? What strategies are you using to detect critical real-time SUD signals you need to build such a system?
That's a great question. So as I said, like our project is funded by NIDA at the moment. In the first cycle of funding, we did not have any plan for a dashboard. So now we are in the process of designing the dashboard now. So the version that you see is a slow alpha version of the dashboard. We are basically communicating with researchers or subject matter experts from many different universities. I work with UPenn, Rutgers, NYU, Mount Sinai, and we basically, and of course Emory, and we basically get feedback from the experts and see what they would want to see, and we're building it based on that.
Awesome. You know that I'm going to ask, I think the final question is that it's in that it's an anonymous question, is that can this methodology be applied to other research areas? What is the future of social media analysis in public health?
Oh yeah, I mean, we always try to develop methods that can be, I mean, my background is computer science. In computer science, application-oriented developments are not even considered science. So, but I mean, I don't have that philosophy, of course. But yeah, so everything can be customized, taken, and then applied to other research areas. I personally think so. The possibilities of social media and public health is massive. It's underexplored. We don't do any outreach or intervention using social media for anything. We are trying to establish protocols for that, for substance use and other sensitive topics like domestic abuse, intimate partner violence, and things like that, where people don't go to their doctors to discuss these things often. They go to social media to talk to their peers. So we have to figure out how to use peers, or we can have peer-to-peer support and help and intervention based on social. It's a very hard task though to convince IRB that it's not going to increase risk for the individual. So that's where the bottleneck is. I mean, how do we prove that if we do social media based interventions, there's no increased, it's not increasing risk for these people?
Okay, awesome. And Miranda, can we ask a few more questions or the time is over?
It's up to Dr. Sarkar.
I can answer a few more.
What do you think, David? Okay. So you know that, let me just say, see. Okay. For example, Banky asked this question: emojis confer a lot of information about the emotion and thoughts of the user. Have you or do you plan to include this as part of the NLP?
We do, yes. It does give us a lot of information, and not only for this study. Again, it goes for every single project that we are running. So, for example, even the colors of the emojis can be informative. For example, purple is more common for domestic violence and intimate partner violence, if I recall correctly. So these are automatically incorporated in the machine learning. In fact, for substance use, the DEA has a report somewhere which has all the emoji sequences associated with expressing substance use. So there are emojis for taking heroin, for taking Adderall, for taking benzodiazepines and stuff like that. So we hope that those are automatically taken into account by your machine learning model.
Awesome. You know that another question is, have you studied the fact that some patients, after they finish being treated with opioid-based drugs, turn to other substances due to their developed addiction during the time of medication?
Yes, so that's exactly what the study where we were looking at the tapering stuff. That's where we looked at what other substances they take, or because that was very of a high interest to our medical experts. So we found substances or drugs like clonidine. I don't really know what that is, like Imodium. I know that's for, I think, some metabolism related substance. So they take those. A lot of people report to taking benzodiazepines like Xanax, marijuana. So we found a lot of that. A lot of people report exercising as a good way to handle it. But yeah, I mean, there are too many people trying to overcome their substance use disorder, and they're trying a lot of things, and there's a lot to learn from the ones who are actually trying really hard and succeeding. So.
Okay, so I promise that it's going to be the last question. So, you know that the next question is that you will go through all, this is a question actually, will you go through all users' tweets to find the age related information? Or I think the question is that you are going to sample of the tweets or all of the tweets, or based on the limitation of the API 3200?
That is another great question. So we did go, I mean, age and gender, etc., though they were relatively easy to identify. So yes, we go through all the tweets of a user, not manually, but we try to filter out possible tweets that will contain that information and then manually annotate them. The difficult was and we are conducting a study now, which is on clinical and social impacts of substance use, which again are not in the posts where they talk about their substance use, but which come typically much later. And annotating that has been extremely difficult because we do not know how to search for those for pre-annotation. So our annotators had to go through thousands and thousands of posts to find, I think, 300 expressions in total of clinical and social impact. And I think they went through over 20,000 or 25,000 posts to go through, and took years. So yeah, it's a tough work. But then once we have that clinical and social impact data in place, we can then train machine learning models. We also release our data as much as we can publicly, as we are allowed to by NIDA or Twitter or Emory. So we are planning to clean that up and release that as well.
Okay, great. Thank you so much, Abid, again for your great presentation. That was very interesting, and you know that we got that a lot of participants and a lot of questions from the participants, and I just want to thank Miranda as well for arranging that this seminar and this talk, and finally that the participant. Thank you so much for your participation, and that for your great question. Abid actually post his email in the chat box. So if you have any questions, feel free to shoot email and ask your question. Okay, if there is no other concern, that I think Miranda is here. So I think this is the end of this seminar, and thank you so much again. And I hope that we see Abid again in our monthly seminar or other activities.
Thank you so much. Thanks for hosting me. Thanks, Miranda. Thanks, Amir. Thanks everyone for attending. Hopefully you enjoyed it, and feel free to reach out with whatever questions you have. I'm happy to answer. Okay. Thank you. All right. Bye.
Thank you again.